The following Agio-supported podcast is intended for informational and educational purposes only and is not intended as medical advice. Please speak to a healthcare professional before making any treatment decisions. The guests on today's show were paid to participate in this podcast.
What's up, G-Codes listeners? It's me, Dr. Z.
And me, Dr. C.
Dr. Callahan, we are live from Stowe, Vermont.
We are. And I'm excited. We have another guest host today.
It's been quite some time since we had a surprise guest host with us.
Dr. J.
Dr. J. Dr. Julie Kanter, the one and only. She is going to be co-hosting this very special episode of Cheat Codes with us. This episode, Dr. Kanter, is called So What Did I Miss?
Cool. I'm happy to be here.
We're so happy to have you. You're going to help us walk through with our faculty guests what happened at the NASCC meetings in 2023, 2024, and walk the audience through what they missed.
All right. Well, I'm going to start actually in 2022, if that's cool with you.
That's perfect. But before we even start there, why don't we introduce our guests?
All right. Well, of course, I'll have to start with Dr. Sophie Lanzkron. She is our VP and has been a co-founder with us from the very beginning, was there when we came up with the idea, really right every step of the way. My friends at home, I think, sometimes know who Sophie is, and I forget that they haven't met her. So very happy to have you here since I'm hosting and you're my guest.
Oh, thank you. I'm delighted to be your guest.
So we met the first time at NASCC, and very excited to have Dr. Coyne. He is one of our evolved sickle cell disease specialists that is now teaching others how to become a sickle cell disease specialist. So very cool role in what we're doing. And then Dr. Leonard, I had the opportunity to meet thanks to John Tisdale, who I worked with for some time. And Dr. Leonard was originally working up in the DC area. Now she's joined us in the South. And I'm very excited to have you here as well, Alexis.
Likewise. Thanks for having me.
Agios is a biopharmaceutical company that's fueled by connections with patient communities, healthcare professionals, partners, and each other. Building on these connections and the company's unmatched leadership in PK activation, Agios is pioneering therapies for rare blood disorders, including PK deficiency, thalassemia, and sickle cell disease. To learn more, visit us at agios.com. That's agios.com. To join the conversation with other patient allies, follow us on Instagram at Ally Voices Rising. That's Ally, A-L-L-Y, Voices Rising.
Awesome. Well, with those introductions out of the way, first of all, I've got to say, calling him an evolved sickle cell doctor is like a Pokemon, and I kind of love it. Oh, Pokemon. I feel like we should give these out at the NASCC conference, like little tokens of what an evolved sickle cell doctor looks like. That being said, let's start now, like you said, in 2022.
All right. Well, 2022 begins with belly dancing. Oh,
I was not expecting to be the word.
The belly dancing.
But I am intrigued.
So we set up 2022, the NASCC meeting in Hollywood, Florida, because it was a resort that I knew people would like and want to come to. And remember, this was the first year and nobody really knew what we were doing. So we wanted to make sure people joined, and we had a lot of group dinners because back then there was just 45 attendees. So we could all go out to dinner together.
Yeah.
And why don't you tell us about the restaurant that I took us to?
Oh, it's fabulous. I can't remember that much about the food. I don't really, but we were all sitting there. It was crowded. There were a lot of people, long tables. And all of a sudden the music started. Next thing you knew, there she was, the belly dancer on the table.
Oh, my.
Belly dancing. And I'm like, well, Julie, is this going to be the theme? And sort of the tempo of NASCC is that it is, we have fun. Belly dancing.
We did have fun. It was a Greek restaurant. The food was actually quite good, but nobody remembered the food. I'm lucky that we remembered what we even talked about after that experience. But you were there, Dr. Coyne.
I was at the end of the table.
What did we talk about at the actual meeting?
Oh, boy. So that was the beginning of our conversations about pain and taking care of pain in the hospital. That's the biggest thing I remember from that meeting.
That and the echo fight. That was the first time I saw Dr.
Fight.
It was a heated discussion on how often one should have an echocardiogram between Dr. Klings, who would like an echo every other day, and Dr. Lanzkron, who would maybe like to not have people get echoes unless they really need them.
I think it brings up a really important point about what we do at these NASCC meetings. So there are evidence-based guidelines that are, systematic review is done, grade is used. And with those, there were evidence-based guidelines that said, don't use echo as a screening tool because it doesn't meet the criteria as a good screening tool. And this is different than what we do at NASCC. We do not do systematic reviews. We are not using evidence-based in grade. We are coming to consensus using a Delphi process. And so one of the rules is, thank goodness, one of the rules is that we don't contradict the formal systematic review grade process guidelines that are out there. We help expand and help to provide tools to implement some of those guidelines.
I will mention the one issue with the echo. Well, there was 2 other societies that have thought differently about an echocardiogram. And I joke about this a lot because who knew so many hematologists and sickle cell specialists cared about an echocardiogram. But it does make people laugh every year. So, and we did. We started talking about pain at that meeting and how we could come together and harmonize. And the other part that I remember best about that meeting is most people know I'm a pediatric turned adult sickle cell disease provider. And so I had spent a lot of time being a pediatric and an adult provider.
Sure.
But a lot of my colleagues hadn't spent any time talking to one side or the other. If they were peds, they stayed with peds. And if they were adult, they stayed with adult and sometimes pointed a lot of fingers. And it was the first time I got to really watch everybody come together and realize in a way that I'd already understood that this is a lifespan condition and we have to take care of that. These individuals, knowing that they're going to live lives, right? For a long time, that wasn't true. But now we get to see these kids grow into adulthood and how do we help them live good lives and strong lives and fruitful ones?
Yeah.
So it was one of the first times that I really got to watch that come together. It was pretty cool.
So that pain conversation I'm really interested in. I'm actually very interested in the echo fight as well, but let's go to pain. Dr. Coyne, what do you remember about the conversations around pain that happened at that meeting?
Well, I remember a lot of strong opinions.
Yeah.
And I also remember, this was years ago, and we're also just starting to get to know everybody. So one of my first experiences getting to learn about how other people do things and how other people think about pain and treat pain, and then hearing in the room what people's experiences were and what they worried about. And then having people come together and slowly but surely develop consensus over time, right? Starting in 2022 and then subsequent years after that, to really create a toolkit for people to take and some direction to take forward.
So what I'm hearing is it may be that a consensus discussion starts in one year and then overflows into another.
Sometimes it does. And in fact, it took us a little while to learn that as well. And sometimes it's just that we don't quite have enough data or we all need to go back and do more reading. And as many people know, the reason we don't use grade evidence isn't because we don't want to. It's because, unfortunately, so little appropriate research has been done to this day in sickle cell disease that we have more expert opinion than we have data. And if we come together and do what's called practice harmonization, but at least start all agreeing that there's a minimum standard that we all need to meet, then we can study the effects of that in a much more robust way.
Mm-hmm.
And I think that's the other thing is watching people come together, seeing them slowly be like, all right, I concede you that point.
I love that. I have a practical, I'm sorry, Dr. C, I'm not letting you jump in here.
Cool.
I just had a practical question. You talk a little bit about this lifespan condition. I'm curious, are there centers that represent the same healthcare system that have peds partners here and adult partners here?
There are a few lifespan centers, and the definition of that is going to change a little bit for a couple of different reasons. Truly, a real lifespan center has one medical director that's overseeing, or one sickle cell specialist that's kind of overseeing both sides. And to this date before that, it had been just 2 centers that had those 2 places in the same hospital system. That's harder to navigate in some ways, but yeah, so sometimes it's a peds and adult clinic that literally exists within the same hospital system.
Sure. Okay. Thank you for clarifying that for me. So we've talked about the 2022 meeting.
That was Hollywood, Florida.
Hollywood, Florida.
People belly dancing.
Echo fight, pain. We go from 2022. You walk away from this successful meeting and you feel like you've got something now. We've got a little critical core of people that are invested in this. And you come to 2023. What are you thinking going into that 2023 meeting?
I want to say one more thing about 22. and we don't have someone to represent. But the other really cool part was our social workers. We had this core group of 9 or 10. Your social worker from Hopkins brought our son.
Yeah.
He loved the ballet. Now he's like,
Oh, yeah, that was great.
and it was the first time, honestly, that they had met other social workers that did the same thing they did. And that was really cool. And I think that was one of the moments that still gives me goosebumps, was that moment. So I didn't want to leave that out.
That's great. That's great. I love that. And I want to hear more about, did the social worker core group of people continue to sort of build out their own little niche within?
They have. And I mean, they have meetings. They have monthly meetings. They're more organized sometimes than we are. They put together their own white paper that is really important, because I think our social workers get tossed around a lot in our systems, and unfortunately, get somewhat used in the wrong way. People don't understand what they're supposed to do, so they make them do other things, and they kind of put together, here's what we're actually going to do, and to really elevate themselves, which is pretty cool.
I love that. So let's go into that time machine. We're going from 2022 to 2023. 2023 happens where?
Oh, bloody hot.
Vegas, baby, Vegas.
120 degrees.
Oh, it was so let's see a recap. That's it. It was just
Well, I was like, it was hot. Can't talk about it.
yeah.
In reality, Vegas was a learning experience for throwing a meeting, hosting a meeting. It had actually very good points that very few people remember. The social workers, by the way, they loved Vegas. They still tell me that. But everything was air conditioned and connected. What made Vegas an ideal place to actually have a meeting, though, was the amount of activities people could do. A lot of people wanted to bring family and spouses, but also they know how to do conventions well, and for a not too expensive. And we hadn't yet brought in sponsors, and so we didn't have a lot of money. And so it was the easiest way to spend the least amount of money and still get, at this point, we went from 45 to 110 people.
Because nobody goes to Vegas in July.
How was your experience in Vegas?
On the record, I thought it was great. Food was good.
Like somebody won.
It was inside.
Yeah, somebody won.
Dr. Leonard, we need a tiebreaker here.
Yeah.
Dr. Leonard was not in Vegas.
I was not in Vegas.
Hey, was it because it was too hot and you knew better?
No. No, I'm the junior one here that's very invited or excited to be invited to this party. So I'm here now.
She missed out,
And
so
we'll
that might mean we go back to Vegas one day so that the juniors can get their answer.
I'll be there.
So at 2023's meeting, what were the highlights? What do you remember vividly?
Well, Sophie only remembers that it was hot.
Apparently so.
Yeah.
I remember the Italian restaurant because it was delicious. In terms of what we actually talked about, we still had our consensus topics were still sort of at the forefront. I know that was where we talked about starting the sickle cell specialist sessions.
Mm-hmm.
Dr. Coyne, you led those.
Yeah.
And explain who you are and why that's so important.
So I'm Francis Coyne. I'm a adult sickle cell doctor without a hematology background.
Okay.
Right. So I'm a med peds doctor, residency trained. Sought a lot of my skills taking care of people with sickle cell disease sort of on the job and having mentorship at my own institution. And this growth, we sort of talked about transformation, whatever word you used.
Evolve.
Right. Evolve. Yeah. Like you have to catch me first. But the growth that sort of I was able to go through and see other people go through, right, led to this question about, well, how do we determine who is a sickle cell specialist, right? Because depending on where you train as even a hematology fellow, you may not see people with sickle cell disease. Right. So we started that meeting to really determine what are the core competencies of an adult sickle cell specialist, right? What ought we expect them to be able to do and demonstrate that they can do? And importantly, right, because Julie's an adult sickle cell doctor from a pediatrics background, we sought to define what are the pathways, right? What pathways can you take to become a sickle cell doctor, right? So practice pathway, so to speak, having some fellowship training or training in fellowship where there was no access to real sickle cell care, and then how much you fill that in afterwards or during your fellowship.
Wow. I have a lot of questions about that. Do you want to jump in?
I want to hear your question.
Okay, so I really want to know about sort of some of these core competencies. Like, what does that talk me through that. What do you mean? What is a core competency?
Yeah. So it's a expectation of what a sickle cell doctor might be able to do, right? So you think about chronic conditions,
Okay.
right? Can you screen for, evaluate, manage sickle cell nephropathy, avascular necrosis, right? For acute complications, can you manage acute chest syndrome? Manage delayed hemolytic transfusion reaction to hyperhemolysis, right? In our patients who have cirrhosis, right? Can you help augment their care as the sickle cell doctor by guiding sort of diuretic dosing, for example, right? So really taking the picture of a person with sickle cell as a whole body, right? The whole person and all the organs that are involved and what that specialist ought to be able to do to manage.
It sounds like this was probably a very active discussion.
It was,
Mhm.
though in some ways it was one of the easier discussions. There was so much agreement.
Mhm.
I think that was also notable that we all right away agreed that you didn't have to be a hematologist because there are a lot of hematologists without expertise in sickle cell disease. And so if you imagine it that way, you can't go backwards. But you had to have working knowledge of all of the things that Francis mentioned, but also blood transfusion. You can't be a sickle cell specialist and not know how to transfuse or not know what someone needs in terms of transfusion.
Right.
Pain management.
Mhm.
You have to be able to do these things.
And I think one of the key pieces, right, is around pain, right? Do you outsource your pain management? How does that integrate into being a sickle cell expert?
Mhm.
Right?
One of the reasons this is so important is one of the definitions of a sickle cell center has to be led by a sickle cell specialist. So if you're going to say that, you have to define what a sickle cell specialist is.
Right. And we want to encourage it, right? So one of the arguments, well, there aren't enough sickle cell experts, so you can't have everyone see a sickle cell expert. But no. Right. We have 120 something NASCC centers. We have the Sickle Cell Treatment Demonstration Project with 5 regions across the country with state leads in just about every state that are there and can provide guidance and care for people with sickle cell disease. And where there's not, right, we need the kind of people who want to do this kind of work. So Jim Ekman once told me, right, that the person who sits at their interview for medical school and says, why do you want to become a doctor? Well, I really want to take care of people, right? Like when people mean that, right? When those are the sorts of people who go and do this work, and that doesn't mean being a hematologist. It means wanting to learn and wanting to care for this complex patient population.
So putting that together, I guess, having identified the things you need to have in your toolkit to be a sickle cell specialist and acknowledging that there's not enough of us and we need people who care and need to evolve into a sickle cell specialist. Have you put together sort of guidelines or pathways or ideas of how to go from, I'm a pediatric sickle cell doctor, but I'm going to run an adult center. How do I make that leap? Or I'm an internist. How do I pick up transfusion medicine? How do I or all of us, how do we learn more about pain management?
Yeah. So we have some unpublished data now that sort of looked at the growth and pathways of sort of non-hematologists. And there's a variety of pathways, right? Some people do the sickle cell specific fellowship programs, which are wonderful. Others found their mentors, right? Mentor might be sort of at their institution, might be somewhere else. Dr. Lanzkron, I told you, has been a mentor for many people along the way whose name has come up to really, as they took care of people, grow up their expertise.
Sure.
I think one of the next steps that we're going to be really looking into is how do we develop that pathway, right? And we can look to other disease states, right? There's cystic fibrosis has a training program that they support physicians' growth into CF doctors. And in hemophilia too, there's sort of a training program to have to really train people in hemophilia.
And so does palliative care, actually. So you can go into palliative care as having been an internal medicine resident, so it's all these different pathways in. You could do that from an ER residency to palliative care. It's a 1-year fellowship. But we don't want everyone to have to do a fellowship. We want to be able to also have pathways that are learn on your feet with a mentor. And so looking at all these different ways and then trying to figure out how we optimally credential someone.
Yeah.
So we have the core competencies needed. That's what's been defined. That's what was defined in Vegas. See, we told you something that happened in Vegas. And now we have to figure out how we hone those pathways. And we're looking at developing some other sort of led fellowships in sickle cell. And there's 2 right now. One's at St. Jude's and one's at Boston Medical Center. So how do we grow those? I would love to have that as an option at UAB, to be able to have anyone who wanted to do sickle cell disease come be a fellow with us for a year.
Very cool. Very cool. So now going back to Vegas, we got through the competencies of these physicians. And then I think the other thing you told me that pain conversation continued on into 2023. Yes. Or were there other
We also talked about iron. So, it's interesting. You can read several different articles, some great ones on how you manage iron and thalassemia, but you can't open a book and really, or a journal specifically, and there's not a lot on how to manage iron. There's a lot about the importance of managing iron in sickle cell disease. But the things that we think of, how often should you do a liver MRI? When do you need a cardiac MRI? These are not data points that are spelled out, so they require consensus. So that's actually sitting in my inbox, waiting to be formatted for a final vote. So we're almost there, 2/3 of the way.
Oh, nice.
So those will be coming soon. That was one of the other topics that we talked about in Vegas.
More. How often to do echoes?
Thankfully, we didn't weigh the echoes into the iron discussion as much, though it did come up.
I'm curious, give us a teaser on where we're landing with this iron conversation. Is there some, are you leaning in one direction or another as far as consensus yet?
Oh, yeah. So we're 2/3 of the way. So the way I should tell you, right? The way the consensus process works, we talked about it a little bit, but we have a vote early on that goes to all centers. And it's a combination of what should we be doing and what is our practice pattern now. And that's how it's answered. And every center gets one vote. And so if you are a lifespan center and have 2 different, a peds and an adult lead, each of you get a vote. But as I said, we're going to kind of change that definition for that reason. But anyway, so that's the prelim vote. And then we come and meet.
On that prelim board, how do you frame those questions and what gets into that? Because
we're getting better and better at those. They're a little more vague because what we're trying to understand is where there's areas of practice overlap or thought overlap versus hard and fast rules. So by the time we're done, for example, that question about a liver MRI, right? We might have phrased that original question. I don't remember exactly. How often do you get liver MRIs in your individuals living with sickle cell?
Sure.
Whereas the final vote will say, we'll say you should get a liver MRI every year in somebody on chelation therapy or with ferritins greater than 1,000. So it's a much more defined, this is what should happen versus what are you doing now. So we start with the what are you doing now or what do you think should be happening? And then it ends with the this is what NASCC says should be happening.
Okay. So 2/3 of the way means that there's still 1/3 left.
Right. We have one final vote to go. So after that original vote, we come meet in Vegas, hash it out, talk about all the areas that we already came together, where we didn't come together, and then identify those items for final vote.
Very cool. Very cool. Okay, so we hit the iron discussion. Are we done with Vegas?
I think we were mostly done with Vegas. And we did talk a little bit more about pain.
Yeah.
So now we're going towards 2024. 2024 happens in
Minnesota because, everybody was tired of hot climates.
Yeah.
And I got a lot of feedback that they didn't want to go somewhere with 110 degrees. So I said, okay, let's go north to the middle of north and stick in the middle of the country, right? There's a great debate on whether we go east or west. I compared this in our opening session this year to everybody's a Goldilocks. I cannot please everybody. Somebody wants to go west, somebody wants to go east, somebody wants the beach, somebody wants mountains. Very complicated, this choosing of the location. But that's why we ended up in Minnesota. Originally, we had a couple other picks. Some of them we took back to the executive committee, and Kansas City was one of those. We got a hard no on Kansas City.
Goes to Kansas City. But really, who goes to Minnesota?
So we landed in Minnesota, filled up the Marriott in Minnesota, used every room they had, and that was where we realized we'd outgrown the single hotel model.
What was our number?
235.
So now we're up from one.
We're doubling every year.
Yeah.
Mm-hmm.
Wow.
It was 170 in person. So 170 in person, about 235 that was the first year we invited industry.
Yeah.
So that was the first year. And what we did there was an exhibition night. So instead of having sort of an exhibiting area, we all went to a bar, a brewery, and had every exhibitor had a table. It was actually a lot of fun.
No belly dancers.
No belly dancers. They're also off the list, along with 110 degrees.
Okay, so we're in Minnesota. We're temperate. We have more people. What are the topics of conversation at this NASCC?
This one, we really dived in to really complete this inpatient management, making sure we had community present around these conversations, because some of these recommendations are a real change to how many people practice.
And specifically about pain, the inpatient pain.
Right, inpatient pain management. Yeah.
And it was Dr. Leonard's first meeting. And specifically, one of the other sort of fast and furious topics that we had to elevate to bring up sooner than we might have planned was talking about who should do gene therapy. Okay. And that was really Dr. Leonard's specialty. So she came in to help us not say who should get gene therapy. That was more of a topic that we're actually working on now. But talking a little bit more about what our transformative therapy centers should be. So what centers should perform gene therapy?
Interesting. Dr. Leonard, you want to walk us through some of that?
How can we ensure that our patients are going to get safe and effective care in the same way that they would on a clinical trial, right? So the question at the time last summer was really, what do these centers need to safely get a patient through gene therapy? And so for the, group of us who had participated in these clinical trials, there's a lot of trial and error. And so, taking that experience, what had been published so far, and coming up with that first survey, asking centers, right, first, have you participated in a trial? Do you have transplant at your center? Do your patients want gene therapy? Is this, what are the barriers you see in your hospital system to become a qualified treatment center? And then sort of getting into the specifics that we could identify as really crucial elements for somebody who wants gene therapy. So, that's going through many different categories. That's the personnel, who are the experts at your hospital, the resources that you have available to you, right? The experience, and then, what are people's views of, managing a patient before they get to gene therapy, right? Because that's a long, sometimes months, if not a year process to get to the actual transplant. And then managing these patients after transplant, and how to really integrate your multidisciplinary team with your transplant team to hopefully have a successful outcome. So that's sort of where we started, was doing that survey and then coming together in to talk about each of these different aspects of gene therapy delivery.
And she is right, by the way. I was that actually happened in Vegas. See, I can't even remember. It was Vegas. That was actually in Vegas in 23.
Okay.
So
we're a year behind in our time travel.
Yes, we were. And the conversations continued.
Okay, fair enough. So I'm curious then, what the key insights, key learnings that you had that were perhaps surprising out of the information you solicited from the centers?
I think it's not surprising, but, to see it in numbers and on paper are, some of those barriers. We strongly believe that our patients need for example, the psychological support early on in this journey and, throughout right before transplant and then thereafter. And, a lot of centers don't have the psychological or psychiatric team support that they need at their institution, or that are available for our patients with sickle cell, or a social worker that is dedicated, or in some cases at a bigger center, you need multiple social workers, access to fertility preservation. I mean, you name it, all of these things that you could kind of foresee as a barrier to care. But what is most important about all of that is, and the way that we frame this is, if you want your center to be a qualified treatment center, which we hope that all of our NASCC centers can offer all of these FDA-approved therapies, these are all resources that are going to make your center better. that all of those patients, the majority of patients who are not going to get gene therapy, should have access to all of these things.
Right. Ultimately, just benefiting the entire sort of ecosystem.
Yeah. And I think, right, the one perspective is what does a NASCC center need? The other part is what to really describe how this should be done in the best possible practice, right? A transplant center that decides one day that they want to start doing gene therapy for someone with sickle cell disease can't do that without the support of a sickle cell center. And that was another important piece of this, is to really spell out that if you're going to do this correctly, these are the tools and these are the pieces you need to make sure that it's done safely and appropriately on the right patients.
Fantastic. That's fantastic. So we covered gene therapy. This conversation goes from 2023 into 2024. What else comes up at the agenda for 2024?
So 2024, we realized that we needed to slow down and publish some of these recommendations and get everything on paper. So we backed a little bit down from this. So in 23, we had the gene therapy, we had iron, we revisited pain, and we had sickle cell specialists. So we said, we're only going to choose 2 main topics in 2024. But we're going to do 2, what I would kind of call prelim or working topics. And this was something that I think we'll continue to do, saying that we're not quite ready to make this a true consensus, but we need to talk about it first. And so this is where we started talking about who's the right person living with sickle cell that should have gene therapy. So not who's the center that should do it, but who's the right person. And then we also started a discussion about community-based organizations and centers. A lot of times you'll have centers that are asking questions about, how do I share data with a CBO? Or what are kind of the rules of engagement? Can they come to our clinic and see people living with sickle cell? What does that look like from a HIPAA perspective? All of those things. And what are those rules of engagement? And so we actually had a group that came in to really talk about how we could do that and just start the conversation. And then this year, really finalize it into consensus statements.
Were you surprised at sort of what the national landscape was and how interactions occur with CBOs and clinics? Was there any?
Dr. Lanzkron, what do you think?
Yeah, I mean, I think there's a lot of variety in how those interactions happen and personalities of the individual CBOs and what individual CBOs can do. And really, there are some communities that don't have strong or available community-based organizations, and how do they get the work done? And so there were a lot of unanswered questions, and it's a complex landscape.
Yeah, no, fair enough.
And it's also hard because unlike what we've now done with sickle cell disease and identified what a sickle cell center is, what a community-based organization is can be very complicated, right? They do many different things and they're not at all the same. And so it can be very hard to put down even expectations for each one. In Alabama, we have 6 sickle cell community-based organizations in the state.
Wow.
But they operate very, very differently. And so it makes it a little bit complicated. So one of them, by providing transportation, physically has a van and goes and picks up people around the state and brings them into Birmingham. And that's in Tuskegee. Whereas another one gives gas cards.
Yeah.
And a third one will help with Uber Health, but only in the center of Mobile. So even something as easy as transportation can be incredibly complicated and not so many rules. So it's hard to make that one-size-fits-all sort of engagement rules, but that's what we've been starting to work on.
Very interesting. Very interesting. So you did take a little pause to sort of start getting some recommendations to paper. What recommendations come out then? Does this slowdown sort of result in an output from NASCC?
So we put everything online first because we didn't want to wait any longer.
Yeah.
So I think that was the first thing is we redid parts of the website to host all of the consensus recommendations that had final vote online.
Beautiful.
And then we started actually putting it all to paper, figuring out what journals would be best.
Yeah.
So we've had the Journal of Sickle Cell Disease, which published the Delphi method that we use. And then our transition and electronic medical record guidelines or recommendations just came out in Blood Advances.
Great.
We took our huge screening papers. So each age group screening paper was about 6,000 words.
Wow.
And we had to condense it into 3,500 words, which was a challenge.
What were the age groups?
0 to 2, 2 to 18, and 18 and up.
Okay.
And that actually just got reviewed and returned this week. So we're hopefully going to be able to resubmit that. So that'll go to JAMA Network Open.
Nice.
And then Alexis and I are getting ready to submit our gene therapy. We're writing up the sickle cell specialists.
The pain one is being worked on actively.
Wow.
Oh, yeah. So hopefully we'll be ready to go in.
Of output.
And I can imagine these are great opportunities for young people to get involved and
Yep.
work with mentors and get publications and really get a start in academic.
And not just that, but so Alexis, after we did our gene therapy centers recommendations, and even though we are still working on publishing those, she had the opportunity to go to SCDAA and talk about those to our community.
Oh, great.
So not just make
Yeah. So I'm that junior person that really gets to benefit from all of this. It's incredibly impactful. For me, it's humbling. It's energizing. I mean, the people you're sitting with in that room are people I've studied, I've cited many, many times, admired. And so to be in the room and have these opportunities, like I cannot express enough how exciting that is for me and my career. So thank you.
Happy for that too. Thank you guys.
Oh, that's so
Well, yeah, I mean, I still kind of think of you as junior. Is that wrong?
No,
That's not wrong at all. Okay.
But it's so important to us. It is so important to us that it is the young people who are taking first authorship roles on these papers and sort of running it through, right? I don't need another.
I mean, I remember early in my days of clinical medicine, it was so cool for me to be in the room where it happens, right? Like just to see the conversation and what academic debate looks like. And yeah, sometimes it can get ugly, but it's all coming from a place of passion. And it's nice to see that. It's really cool. So thank you guys for including the juniors in this.
Well, not just that, but really we want them to help lead. So if there's something they're interested and passionate about, I know Alexis is really passionate about gene therapy and making sure we do this well and right. And so I don't need to lead this. I've got enough to do, right? So giving others the opportunities, that's how we grow our field. And I think it's something that sometimes some people did really well in the past and some maybe not as much. But I'm hoping we continue that and continue to bring it forward.
Yeah. So for me, being on the pharma side now, hearing about, the first conference being 2024 where pharma comes in. First of all, thank you.
23.
Oh, 23?
You got right? 23? Oh, no, 24. You're 24. Clearly, I don't. Yes. Sorry. All right. Go ahead. 24.
So I just want to just express my gratitude for having the doors open for us as well, to benefit from being around people who share sort of common ground and passion for sickle cell disease. The 2025 meeting for us has been very, very transformational, I think, in just seeing the way the sickle cell community has grown.
Yeah, it's absolutely amazing. I didn't know what we were walking into. I got to registration and I saw all these people I've never seen before. And then I heard how big this was. And then just participating a little bit in the meeting. Hats off. This is really amazing. I think this is something that sickle cell is needed for a long time.
So let's go back to location discussions. How do we land on Stowe, Vermont?
Oh, Goldilocks. And the three bears, because, there's bears in Vermont.
Yeah.
In fact, one of the restaurants I went to for dinner, it actually has a sign that says, when bears are outside, please wait to go to your car.
Oh.
So apparently that's not that uncommon. No, it did seem like good advice. So to answer your question, as I kind of had mentioned, Miami was the beach and that was great, but it was too hot. Las Vegas was fun, but it was way too hot. Minnesota was cooler, but not fun. So it's a rough crowd.
Prince's house.
Pardon?
You didn't go to Prince.
Some people did go, actually, to see the Prince's origin. But so I wanted to look for one thing that's also really important is in our creating community, which is a community of all of us, people that want to look forward to this. Because, it's hard sometimes in sickle cell. It's a hard group when you don't have enough money and you don't have enough support and a challenging disease where we don't have a lot of options. So we want to make sure we get the opportunity to bring people together in a way that's fun. So I looked for fun towns and small convention centers.
There's a statue of Mary Tyler Moore.
Okay.
Yeah.
Yep.
Well, that's the highlight.
Yeah.
Okay.
And it did, and a sign that says Prince this way. But not as much as, family sort of activities do. And so looking at all of those combinations and trying to get somewhere with cool weather, and knowing that we were going to grow a little bit more space, so we needed to increase capacity than we had in Minnesota. And we only had a few options when you did all of that, and we ended up in Stowe, Vermont.
I've actually been pleasantly surprised. It's actually beautiful. It's beautiful here. I almost died on a hike, but it is beautiful here. And we've gone now, we're tracking these numbers, right? So double digits, low triple digits, you get to 250 or so. And now we're at 400 plus.
So altogether, as of this morning, was 650 registrations with 330 in person.
That is amazing.
And representation from over 75% of all our centers in person.
And while I haven't been in any of the consensus meetings, the depth of the discussion that's happening at this meeting is formidable. I mean, it's truly experts in the field just conferring over important clinical matters. Tell us a little bit about what you're looking forward to in this 2025 meeting.
So it was really the first time I got to do the full team tracks that I'm calling it. So, Francis leads one of those. It's sickle cell disease for the new specialists. So it's really starting to say, how do we help build those core competencies that he has talked about? And so I really said we're going to have leads for each of these tracks, and you guys get to figure that out. So I don't have to plan all the sessions. So turning it over and letting them really take charge.
Very cool. What are the tracks? What are the other tracks?
So we have an advanced practice provider track. So Ashley Lauriello and now Alicia Felder lead that track. We have a nursing track led by Shannon Phillips and Maya Rudolph. We have a social work track led by Shirley Johnson from VCU. We have a pharmacy track that's probably the one I'm most excited to see grow. Our pharmacy can play such an impactful role in the work that we do, and we don't involve them enough.
Very interesting.
And I've learned at UAB, I got lucky and had a pharmacist in my clinic and really got to understand what they could do. And Mark has been fantastic in the lead of this and is really embracing it. I'm really excited. He's really excited, so I'm really excited.
Oh, that's great.
We had our neurocognitive track.
Right.
And psychology, psychiatry, slowly, they've been part of that, but they're slowly separating out. And then we had something that I didn't have a great name for. So I called it sickle cell disease, et cetera, because it was, you didn't quite fit into any of those things, but topics that we wanted to discuss, some that might be early discussions on, maybe consensus in the future, or just things I know people ask to learn about, reproductive health. Rediscussing acute chest, because it's been a long time since that Vashensky paper that we all quote. And then tomorrow, Sophie's going to talk about Granddad and how you use Granddad effectively. And then Ellen Riker is going to come from the SCDAA and Artemis, which is a policy consulting group, to talk about how to advocate in this crazy climate that we live in. Awesome. So lots of different topics coming in, and then we're going to have a really interesting, I think, transformative session in the afternoon that everybody's kind of co-leading that is about the complex patient.
Oh,
because it really didn't fit, right? Everybody needs this information. So what does that look like, and how do we get everybody together?
wow. Kind of makes me want to go back to clinic, man. This is a really cool initiative, guys. I just hats off to you.
Can I give a quick shout out to Shenya Allen too, who's my co-lead on the specialist track?
Yes, she is your co-lead. And actually, quick announcement, no one's heard it yet. She's going to be co-chairing the whole meeting with me next year.
Love it.
Yes, so
Very choice. You can't overestimate how important these things are socially too. I think, we as doctors work in a silo, and sometimes it's a grind, and to get together with your colleagues who are going through the same things, you build a tribe. And I think that gets you through the tough times. And it's wonderful to hear that's extending to now the social workers have a group, now the psychologists have a group. And these things build that. I think, I believe work hard, play hard. And, I almost left Amar on a rock on that hike yesterday. But I think these things build those bonds and really are a huge rewarding part of your career.
And we deserve it in sickle and haven't had it in a really long time. And we take care of really complex people who have sometimes devastating outcomes, which are really hard for all of us. And, we have little chats that we have when we have complicated patients. We reach out to our friends, and here people make those friends to have the ability to reach out and say, hey, I have this difficult problem. Can you help me? And so, right, it is our time to be able to have this sort of collegial relationship and build these relationships.
Really amazing. It's really amazing. The tribe is stronger than ever, and NASCC has been hugely instrumental in doing this. For those people who haven't been to NASCC, who want to learn more about NASCC, sicklecellcenters.org.
Sicklecellcenters.org, and it'll take a while. It takes several weeks post meeting, but we will actually have some of the meetings up online. Some will be only for members, so you have to have some benefit to being a member.
Sure.
And then the consensus recommendations are there, so you can see all of those. That's open. We want to keep that open. We want everyone to be looking at that. And for those who are interested, you'll have the option of saying, hey, keep me informed, and you'll get a newsletter and find out what we're up to and find out where we're going next when we figure it out.
Beautiful. Well, to all of you, thank you for joining Cheat Codes. Dr. Kanter, thank you for being a co-host with us. You're a Cheat Codes alum, and now you're a Cheat Codes alum host. So,
Do I get my own microphone?
yeah, I mean, you can take that one home with you.
Gold sparkles.
There you go. For those of you listening with sickle cell disease, keep living well with sickle cell. Follow me at Dr. Z Sickle Cell.
And me at Comancheneer.
And with that, we'll see you next time. Peace.